Okay, well, welcome and thank you for coming today. It's great to see so many faces here, and we're thankful that you made the trip over the bridge to join us this afternoon. My name is Brittany Watson, and I work as the practice consultant for clinical informatics here at Providence. And it is my pleasure to have Noreen, Dr. Noreen Frisch, with us this afternoon. Before I have Noreen speak, the plan for today is that Noreen will do her presentation, and then there will be an opportunity at the end to ask questions from the audience. So you will be able to use the mics there. So if you can hold off for your questions till the end. Noreen did say you can interrupt her during, but we'll see how it goes. So just a few housekeeping items before we get started. As many of you know, the washrooms are located just behind the lecture theater here in the hallway. And then if you can just remember to keep your phones turned off to silent. And last but not least, I just want to acknowledge the contributions of a few of my colleagues who helped support getting the presentation organized today. So Shelley Fraser, Astrid Westervelt, and Grant McCullough, thank you very much for your help this afternoon. So without further ado, I would like to introduce Dr. Frisch. Dr. Frisch is a nurse educator with over 15 years of educational leadership experience. She is the academic lead for the InspireNet network and chair of the network's evaluation committee. She has worked with curriculum development, approvals, and accreditation at 4 schools of nursing, including the development of the UVic double degree master's program in informatics. She also chaired a national task force to develop informatics competencies for undergraduate nursing programs in Canada. In recognition of her work in informatics and nursing documentation, Dr. Frisch was elected Fellow of the NANDA International in 2012. Dr. Frisch, it is both an honor and a privilege to have you here with us today. And on behalf of professional practice at Providence Healthcare, I would like to welcome you.
Thank you. Thank you. And thank all of you for coming. It's such a beautiful day. I thought, who would be in a lecture hall this afternoon? So I'm really, really pleased that you're interested enough. And I hope what I can share with you will be of benefit, perhaps for all of us, and for those who listen to this later when it's archived and they can get to it. So I thought I should start by asking, which is a question I asked myself, why am I here? And I provided a discussion on research about what we are doing to prepare nurse executives, and this caught the interest of a few people who were there. And it's a topic I believe it's not just are we ready, but what do we need to prepare ourselves for? And we have to think in this whole area of informatics, which is how we deal with data and how we deal with documentation, where we are and where we're going. I've always believed that it's really, really hard to ask people to develop a vision about something they've never seen, or something they don't know, or that they've not experienced. We can ask nurses and health professionals, what do you want in your electronic health record? And how can they answer if they've never seen one that really worked? And if the only record we have is what a vendor shows us, we might be limited. We ought to look at what are other people doing. And in particular, I think it's important to say if we want to have some comparators, how are other people developing nursing and allied health within their electronic records? Because there are people that are ahead of us, and we know that. So the purposes of my talk will be to describe a little bit of background about that readiness of nurse executives and nurse leaders, to suggest what we might need to know going forward, and to address the issue of what nursing and allied health leaders might do or be able to do if they look at our current situations and try to have some future projections of what might work. So I'm going to give you some data that I have. I'm going to report some material that comes from published works, and I'll give you my own thoughts about what we might do. And I want to say this now, and I think I'll probably come back to it, that when we're dealing with implementing electronic health record, and when we're thinking we're going to be paperless, and we're going to include everything we might need to manage our work, we're in it for the long haul. This is not something we can do overnight. It's a very, very long process, and it is helpful to us that there are people around the world that are ahead of us in this process. And if we look a little bit about what they do, maybe we can figure it out. So why are we interested in this topic? And I would say we've all heard the benefits. We will have practice improvements based on increasingly sophisticated technologies because we're going to use those technologies to capture, store, retrieve, and use data. Information from these systems can support planning safe, reliable, and efficient care, and it allows us to aggregate data or to mine data sets so we can figure out what the best practices are and set achievable outcomes. So we've all heard the promise of we've got to do this because it's going to make us better. But there are some real challenges that we don't always talk about. We do have a specialty of nursing informatics, and we have a specialty of healthcare informatics, but many, many of the people that need to be involved in this process are not those specialists. Nurses in leadership or management positions may not have the background to support the frontline nursing needs, and we need to know, well, who needs to be there with them so that we can take maybe 2 people moving forward from the clinical side. We have data, and it shows us that practicing nurses, nursing faculty, nursing doctoral students, and graduating nurses do not have sufficient knowledge to make full use of information systems in practice, let alone the knowledge to design and implement those systems. I note that there are about 50,000 licensed health professionals in BC who are registered nurses and allied health professionals. While we support everyone's move toward interprofessional and interdisciplinary practice and collaboration, without computerized or digital documentation of the assessments that those professionals make, kind of care they give, and tracking the outcomes that we're getting from their work, we actually have little idea about what all these people are doing. And we have the ability, with an electronic health record, to document a lot of things that currently we can't capture. And the benefit is that we can aggregate that data. So I'm going to give you some examples about that. But let's look at a little bit. I'll report the data on what got me here. There were 4 of us that did a study where we looked at the readiness of nurse leaders to advocate for health information systems that support nursing. And in this case, we were looking just at nursing. And briefly, the question of the study is, are we preparing nurse leaders with competencies they need to advocate for inclusion of nursing in the information systems? And we answered it by exploring the content of nursing and health information systems in curricula, in course descriptions. We looked at what we are teaching our future nurse leaders about this content. And we looked at 36 schools on the West Coast of the US and BC. And briefly, the findings from that study were about 1/3 of the courses or the programs that are developing leaders, and these are nurse executive, advanced practice leadership. In the US, it's the MSN, MBA kind of person. We weren't looking at what we're teaching nurse practitioners. We looked at those people who were being prepared for leadership roles. About 1/3 of the courses or the programs currently require a course in informatics. About 17% offer an elective course on that topic if the person is so inclined, or if the course meets on a day that they can come to school, or for whatever reason they choose to take the course. Other programs had no evidence of attention to informatics content at all. And this is in 2014. This wasn't a long time ago. Content such as standardization of terms, interoperability, interface and reference terminology, system procurement, was evident only in some of the courses that were specifically designed as informatics courses. So that even today, we are preparing people who are going to move into some management, supervisory, executive kind of role without a lot of background, or perhaps with almost no background. So that's a concern. I want to talk about another study, though, and this was done by one of our master's students in the double degree Nursing and Health Informatics. Alan McLean looked at nursing's voice and health information systems acquisition. And this is again saying where do and at what level and how do nurses get involved. And in this study, he explored nursing's contribution to the design and acquisition of systems. And he had a survey that he surveyed senior healthcare executives with a nursing background in BC. And his data show that there is a lack of formal training in IT. People didn't get it in school. But a majority have taken a very active role in e-health, information technology acquisitions, and system upgrades. Most of them had on-the-job training, and many of them educated themselves in their own time, in their own way. 75% had been asked to participate on project teams because their input was considered important. And also 38% went out of their way to be included in certain projects. And we thought that was quite good. He also had something that we call a influence scale, where he asked them who should be involved in making, it's an influence factor, who should be involved in making decisions about procurement. And what he found is that the nurse execs felt that IT professionals should have the greatest influence. They're the people with a background and knowledge about information technology, yet their influence factor was 33%. And that other people, executive team, finance, and clinical end users must also be involved. And the clinical end user came out to be about 17%. So that we need a team of people, which include many different kinds of end users making decisions. His conclusion was that the situation in terms of nursing's voice and nursing involvement was positive and encouraging. And I agreed with him. It's a nice balance to the other study. So if you ask me, what do nursing and allied health leaders need to know? I would say there are some basics. How is an electronic health record organized and built? How do we get information in? And how do we retrieve information out so that we can achieve that goal of quality, efficiency, and effectiveness? And what is HIMSS, and how does it contribute to implement those goals? And I would imagine a number of you here are involved in the HIMSS stages. Am I correct? So I'm going to talk about that first. The letters stand for Healthcare Information Management Systems Society. It's a global nonprofit group. It's focused on better health through information technology. And it's interested in data and insight. So our system gives us data. Our system doesn't give us insight. That's up to us. And HIMSS has set out a series of levels. There is a model, which is an electronic record adoption model. And there are 7 stages in the model that are an objective way to assess our IT maturity. The IT maturity of an organization can be tracked. And these are the levels. They actually have a level 0 if somebody has nothing that is electronic. I think when they first came out, they thought level 1 was where everybody was. But in level 1, it's this institution where radiology, laboratory, pharmacy are installed and data can be retrieved. They are electronic data. And level 7 is a fully paperless system with capabilities to retrieve data in data sets and answer the questions like, how many patients with an MI have come into our emergency room over the past month, and what was the time to treatment? You know, we could be sophisticated and look at all of those things. As we go along here, on level 3, there needs to be some clinical data installed. So that could include vital signs, flow sheets, nursing notes, care plan charting, and or the electronic medication administration system. So people look at this, and I think particularly IT people look at this and say, we want to be sophisticated. So how quickly can we get to level 4 or level 5 or level 7? And I think that's good because I think we have to have a way of targeting and saying, where are we going? On the other hand, but this is what I think is good. It's an objective measure of the maturity. It permits tracking of goals and provides a reasonable pathway. It can support quality of care. That doesn't mean it does support quality of care, but it gives us the capacity. For me, the limitations of seeing HIMSS as our only outcome is to meet certain levels, only one of several options need to be in place. You can have nursing notes, or you can have an electronic medication administration system, or you could have both. But both institutions will be at HIMSS level 3. And you can have some of the HIMSS characteristics, or you could meet the stages in one part of your organization, but not everywhere. So that it doesn't tell us as much as we might think it does. So I would just say that's very important. And the insight, because you have a mature system, or a more mature system this year than you did 2 years ago, doesn't mean necessarily that we've improved care. But we are going in the direction to give us the data we need to improve care. So I always say that that is up to us. I could only find one study, so I want to report it to you, on IT maturity and care outcomes. And this was a study, they called it electronic medical records rather than electronic health records like we do here. It's a study that came from the US, and it's a study that involved 3,048 units of 509 hospitals. And they looked to see if there were outcomes that they could measure from an increasingly mature IT system. They thought that an increasingly mature IT system and experience with it might decrease nurse staffing needs, and they thought it might improve patient care outcomes. So they started looking at this from year 1 to year 3 in implementation. And what these individuals report is there's no evidence that EMR implementation improved any nurse-sensitive outcome that they could measure. In fact, in the short term, in year 1, their data was worse. And they looked at some of the basic outcomes like pressure ulcers and falls. And so they had to think, now, why is that? And there is a learning curve when we introduce a new system for people, and there's a workflow disruption. And so just because the system is there doesn't mean we've improved something. So that's important, I think. And they found there was no evidence that it decreased the need for nurses. They found in the short term there was somewhat decreased need for nursing staff at an LPN or care aide level, but by year 3, there was an increased need for RNs and LPNs. So that at least in this setting, and we have to ask, well, would that transfer here? And do we know? It's the only study anybody's done. We're probably not going to save a lot in staffing time, but we might have better data on what the staff actually do. So my point is that when we have HIMSS as our only goal, I think we're missing a lot. And that's because I'm the clinical person talking. I think if you have the IT person, it's let's just get the technology there. And we need both. So I thought it would be helpful to just look a little bit at how a digital record is organized. And this is typical. It may not be exactly what we have here or what you have here, but it is typical. And in the electronic health record, on the left side of the slide, you have little buckets. One is the administrative one. One is for nursing. One is for lab, clinical, radiology, pharmacy. And data goes into these. And these data are collected and go through a process where at the outcome, we have a record that gives us individual data about an individual patient, and it gives us the ability to aggregate that data. What I think is interesting here, 2 things. One is that when you see these models, nursing is in its category by itself, often. So we have nursing data and we have clinical data. And if we think nursing is a clinical practice, we have to start asking why are they separated and for what purpose are they separated? And I think my answer to that, and I'll show you a little bit, sometimes there are nursing modules within records that are hugely well-developed nursing care plans and interdisciplinary plans where we're looking at a particular patient outcome. And that might reside in the record someplace differently. But there's another part about this record that I think nurses don't think about enough, and that is that when I have a paper record, I pick up the chart, and I can look at every page in the chart. I can go through it and find whatever it is that I need to know. When I have an electronic record, I am authorized to see certain screens on that record. So the record has all this information, but I'm authorized to see something. And a physician is authorized to see something. And most of us as practicing nurses don't know what I don't get to see. And I think decisions are made about what a nurse needs. What does a registered nurse need? What does a social worker need? What does a physician need? And we may ask ourselves, who made those decisions? Because most of us don't know the answer to that. And many nurses don't know the answer to that. Who decided what's the nursing screen? And it's just a point to consider because this is a huge move from a paper record where I can look up anything I want. And I decide what I need to know in order to give care. So I just want to point that out. But for anything to get in this record, it has to be captured digitally. That means it has to enter into the record in a standardized codable term that the system can understand. So we have to have a standardization of concepts. I see there's an error on that slide. And systems have to be built to take words we use in practice and give them a number that is stored in this computer. And I think we know that. And all of us have probably come across SNOMED because SNOMED is the backdrop of our electronic health records in Canada. SNOMED is owned by an organization which is an international terminology standard development organization. It's a nonprofit and at 27 member countries. Canada is one of them. And SNOMED is the global language of healthcare. SNOMED is a controlled vocabulary. That means that there are certain terms or concepts that SNOMED can read or understand. It's clinically valid, multilingual. It enables representation of clinical content into digital records, and it works behind the screen. So when I'm a nurse as a clinician, I don't have to know very much about what SNOMED is doing. I enter my data, and it takes care of the rest of it. So a physician puts a term into a record called myocardial infarction, and the system knows the words, gives it a code, because it's understood by SNOMED, and it's stored and can be retrieved later. So SNOMED has concepts, descriptions, and relationships, and every concept in the system has to have a unique identifier. It's, my colleagues call it a QE, but it's a concept unique identifier. And concepts come from standardized vocabularies for health practice. And those include medicine, psychiatry and mental health, nursing, and allied health. And SNOMED is considered a reference terminology because a reference terminology is something that has the ability to take and understand data from somewhere else. So you know that medical data is captured in ICD terms. Almost everybody that is in this work understands that the International Classification of Diseases is the language of medicine. So SNOMED has to have an interface with ICD. So the words myocardial infarction or diabetes type 2 will be understood. It also captures DSM terms. the Diagnostic and Statistical Manual for Psychiatry and Mental Health, so that if there is a term like major depression or schizophrenia paranoid type, those terms can be entered into this system and understood by SNOMED. So that the ICD in this case is an interface terminology. It can interface with what's behind. I think I've said that. So what happens to data from nursing and allied health? I think we have to ask, what kind of data do you need in nursing and allied health practice? When you know, then you have to ask how you will capture that work with a unique identifier that SNOMED understands or knows. What your choice of interface terminology depends on what you want to know and what you need to get into the system and out of the system. And I think this is a conversation that we're not having enough in nursing and allied health. As we build our systems and envision our systems, we want eventually to think about what do we want from these other disciplines in there. There's no question that we will have ICD and medical diagnosis in their system. And there's no question we'll hire coders to make sure that we've got the right words. And we'll capture and process those things that document that we've carried out medical treatments. So we'll capture that we've given medication. But what more? You know, what more about that practice of the 40,000 nurses and the 10,000 physical therapists and dietitians? What do we know about standardized terminology for nursing and allied health? Another project I did was to review the literature that was available on electronic documentation for nursing, physical therapy, dietetics, speech pathology, and audiology. Wasn't everything, but it was those disciplines. And I used CINAHL, the Cumulative Index for Nursing and Allied Health, as a database to say, what are people describing that they're using, and what are the terminologies and the standardized languages that are currently being used for these disciplines. And what I found, and I'll talk about this a little bit more, that nursing and dietetics have developed discipline-specific standardized languages that will document the full scope of their professional practice. Physical therapy identifies the International Classification of Functioning, the ICF, as its framework for documenting practice, and communication disorders seem to be documented through the ICF or through the DSM, the Diagnostic and Statistical Manual. So what are these? These standardized languages in nursing include the International Classification of Nursing Practice. This is a classification that was developed by the International Council of Nurses. It includes nursing diagnoses or issues of concern for people who don't like to use the word nursing diagnosis, interventions, and outcomes. And it includes a way to code most of those terms that are understood by SNOMED. So we could develop a plan of care, and we could develop a focus of care using that system and document what happened. Many people, depending on how long you've been in nursing, know the NANDA diagnoses. And NANDA has become international, and it has a taxonomy of nursing issues or nursing diagnoses that are used in connection with the nursing interventions and the nursing outcomes classification. And together, people refer to those as the triple N. And then there's the Omaha system for documenting home care nursing. There is a perioperative nursing data set for people in OR practice. I see we've got an OR person here. So there are several others that have been pulled out by nurses. And when you look at, for example, the perioperative nursing data set, things like monitoring hypothermia is, they've picked out what has been very important for their practice in the OR. So we have several others, but these are the ones that are used most often, let's say, throughout the world. I don't know that anybody in BC is using any of these. So I think it's important for us to say, let's look at why people use this and figure out whether it might be helpful to us. There's another documentation tool that isn't really a standardized language, but it is something that can go into a health or medical record that might be useful, and that's CHOBEC. That stands for the Canadian Health Outcomes for Better Information and Care. And it's a system that was designed for nursing, where we're looking at outcomes for which the nurse or maybe some other health professionals are accountable. And it contains 8 patient outcomes. They're organized around things like functional status, pain, fatigue, dyspnea, nausea, falls, pressure ulcers, and then a category they call readiness for discharge, which can really be defined as therapeutic self-care. And it has 12 assessment data elements. And people can take this and say we have a nursing assessment that we have an issue that we might consider to be nausea. And nausea management is a focus of our care. And when do we reach a point where we're ready to discharge a person so that has been handled? This was developed in Ontario. It has been used in Ontario, PEI, Saskatchewan, and Manitoba, but it's not been picked up in all of the provinces. It's different than these other languages because these are really codable terms that get into SNOMED. But CHOBEC is a much smaller slice of information. But everything that is in that tool was developed on the basis of evidence. Only if there was clear evidence that nursing had an impact on the outcome did it get on the list. So that's another consideration. I'll come back to showing you how some of the people currently use these. But my question is, it's very challenging when we're moving from a paper record into an electronic record. And the way we think about charting is narrative. We write down what we see. And in the informatics world, those narrative notes end up in what people call the data cemetery, that we can never get them out. And as useful as they are, we give information to somebody perhaps for a next shift, but then it's gone. And the benefit of this system and why we're spending millions of dollars to develop it is we can actually get something out. For dietetics, the dietitians have developed an International Dietetics and Nutrition Terminology, the INDT. And the Canadian documents really do support the use of the INDT, or the nutrition care process. And when I looked at this information, what I found is that in the nursing languages, there are some issues about nutrition that nurses focus on. You know, nutrition less than body requirements or more, some particular things. What this is, to me, is to pull out that area of nutrition in dietetics and to document the entire specialty practice. Yeah, I thought it was very, very impressive. And some dietitians here in BC are using it in their practice, but I don't know if it's getting into a record. For physical therapy, that International Classification of Functioning, it's the International Classification of Functioning, Disability, and Health, and it's a World Health Organization classification system that was designed to complement the ICD, the International Classification of Diseases, because the thinking was that together they would provide a more comprehensive or a more holistic view of what was happening with a patient. It's endorsed by the physical therapy organizations. And I've wondered, again, when I've talked to physical therapists and some occupational therapists, they say, oh yeah, that's what we use. We document. And so my question is, as we're developing the record, are we going to have an interface with any nursing language or with the ICF or with the INDT for the dietitians? What are we going to do? For audiology and speech, they use one of the other languages, ICF or sometimes DSM, it appears. So what does it tell us? We have terms that can be coded in interface, but we're not talking about that. You know, we're really looking at, let's build the record and let's get moving. Would it make a difference if we had it? Why do people in other places and in other countries develop their modules to be sure they include these interfaces? In nursing, and I have more data on nursing, there's been much more written about this within nursing. The use of discipline-specific terms is thought to influence the quality of care. That seems to me to be because we're focusing on outcome. That we're saying, okay, the nurses are doing something. What is the expected outcome of what they're doing? And when we're using this discipline-specific terms, they're thinking of outcome. And I can remember a person who did a lot of work and published on critical thinking in nursing and how nurses make decisions. This was Daniel Pachut. And he said, you know, nurses can be the best assessors of the world. They go out and they make an assessment, and that we don't often get out of the assessment to say, here's the outcome. And he'd spent a lot of time trying to help nurses understand that the assessment doesn't have to be redone every 12 hours completely. That let's look at where we're going and focus on the outcome. So discipline-specific terms help in that quality of care. In locations where there were use of these terms, the visibility of the profession went up, and the sense of professionalism among nurses went up. And I'm going to briefly go through some of the data. There was a report from Italy that when they used the ICNP, nursing visibility went up and the measurement of outcomes became very clear. So they were quite happy about that. In Norway, nursing documentation is guided by a Health Personnel Act that requires that they document in each discipline. So nursing modules in their electronic record require process documentation. So they had a care plan with notes in free text, because most of the time nurses don't want to give up that narrative note. So they have to have some free text. But they had a real challenge with their vendors, because the vendors didn't have a system that was going to be adaptable to what the nurses needed. And they worked out solutions where they used the Nandanich and Nock interface with SNOMED, and then they had a space where the nurses could provide the free text to contextualize or to expand on those words that were in the codable system. In Switzerland, a group that's doing a lot of work, and I'm going to show you some examples of their record later, they found that there was a huge need for education and learning about diagnostic reasoning for nurses when they tried to implement this into their practice. And that nurses do things without always being able to articulate, what are you doing and why are you doing it? And that's what this record requires them to do. And they had an interactive learning method that was quite helpful. What other researchers said, and these are people from the US, clinical ownership of the record is vital. That if we want our professionals to use the record, they have to feel like they own it, that it means something to them, that they're not just passive receivers of what it is that we give them. And they described how nursing and IT worked collaboratively to meet the requirements of various aspects of care. And this particular paper, because it was in critical care nursing, gave an example about pain management. Plan change is essential, and we would know that. And this article, again from the US, I think it was in Minneapolis, I thought it was very interesting because they wanted to use standard nursing nomenclature or one of these standardized terminologies in an EPIC system. So they had a vendor that is one of the larger vendors like Cerner that many people use here, and they wanted to document within the nursing diagnosis intervention outcome system. And they identified huge challenges with incorporating a terminology as an interface with a system that wasn't designed to do that. And I think if we wanted to, we are probably in a similar situation. And they pursued licenses to get the terminology rights and for master care plan files. And then they had to hand-build the program so that it would be useful. Now, this is a system that was already using these terms on paper records, so that they were already in a mindset that we ought to do this. So considerations, in Canada and elsewhere, these systems could be built to give us this capacity, but we have to decide what it is we want and what of the interface terminologies that would be most helpful to us. We have to talk with our vendors about how to include disciplines other than the medical discipline in a record. And problem lists are helpful. You know, we need to look at problem lists, but that isn't sufficient. That might need to be expanded to other parts of a record. There was a paper in 2006 that called for an expansion of electronic records to include more than just physician practice. I don't know that a lot has changed. Some of us did publish a paper about a few years ago about where is nursing in the electronic health record, because we weren't able to find it. And I want to give you just a quick example of a conversation I had with students, and then I'm going to show you some of these other people's records. But I was with a group of third-year nursing students, and I was asking them, you know, they were saying, well, you know, what do we need to document for? And isn't what we're doing okay? And I asked them, if you came into a unit at 6:30 in the morning and you were going to give care to somebody at 7 o'clock, what do you need to know? And they answered the way you'd expect a third-year student to do. I mean, they did pretty well. They said, well, I need the medical diagnosis, I need to know the treatments, I need the medicines, I need to know the areas of concern. Is the patient stable? Are there comorbidities? What do I need to do? And then they went to another level, and I said, what do you need to know? It's 6:30 in the morning. Did the patient sleep last night? Is pain or comfort an issue? How do I get the patient up? Mobility. What about eating? Is there an issue of skin or continence? The kinds of things here that are completely what we would call nursing. And all of these things are things that are included in those standardized nursing terminologies. So I said, where do you get this data? And all of the data on your left side comes from the record. Where do you get the data on the right side of the screen? Well, it's in somebody's pocket, written in pencil, and they tell me about it. Or it's on a whiteboard, and at the end of the day, we erase it. And so where is the documentation of the nursing practice? And if we're dealing with something like sleep disturbances, which are a big thing in a lot of our hospital settings, and we institute a sleep regime, what's the outcome? Did it make a difference? How do we know? So I thought we ought to think about all of those things that represent that nursing. And I know you can't read this record, but it's in German, so I think most of us couldn't read it even if it was bigger. But I just have a few screenshots from a nursing module and electronic health record from some colleagues in Switzerland. And what they have is a completely paperless system. They're beyond this HIMSS Level 7. And they've developed a very, very comprehensive nursing model. And what they have when you open up the nursing model on this left side of the screen is a list of categories. And it includes things like the demographic information and the medical diagnosis. And it includes categories, physiologic issues, psychosocial issues, function, and it goes on. And so a nurse doing an assessment can look at all of those areas or can pick out the ones that are really targeted for what this particular patient and nurse need to do for their encounter. And they click on the one that they need. They can write in free text things that they want to about that patient assessment or that status. But when they click, they have more information that's specific to that category. So it might be a function. You know, can the person get up? Do they need help with various things? Or it might be physiologic. And what they can do, they chart by exception. Each one of those items is on a 5-point scale. And so if nothing's wrong, they just leave it alone and it stays a little green dot. And if something's wrong, they can slide that scale to a level of 1, 2, 3, 4, 5. And 5 means that this is a really big issue for that patient. And it becomes red when they do this. So that when a nurse comes in and looks at the case, they have a summary record. And in the summary, the left side shows where the nurse and the patient and family have decided the patient should be when they're discharged. And the column next to it shows where we are right now today. And every day or every shift, depending on how often you want to do it, there is an assessment of how well are we doing to move with our plan of care this patient to this level that we said we wanted to be. That's our target. They also have a way to graph this so that you can come on and say, if you need to be in the middle of that circle to be ready for discharge, we have a few areas that are pretty important for us to be attending to. Now, this record will have a very detailed plan of care. It will say for this area, whatever it is. It might be pain management. This patient has pain at a level of 8, and we're going to have to send them home in a way that they can manage that pain. So what are the things we're doing in terms of teaching and medication and other interventions or activities that we would do to help the person? And when is a person ready to go home? Now, do we need something like this? What I can say is that having looked at this, nurses like that little sliding scale. And they like being able to look at, well, there's the little red dot. This is my priority. So they don't have to come in at the beginning of a shift and figure out what the priority is. It's already been done from the shift before, and this is going to be the focus of my work. But the other benefit of this for their facility is at the end of the year, this facility has over 50,000 records. So it can look at individual patient status at admission and at discharge. It can identify what patient priorities the nurses were addressing, and it knows what outcomes were achieved. It also knows how long it took to achieve those outcomes. And if they wanted to, they could look and see what documented activities the nurses were doing to achieve those outcomes. If nothing else, this kind of a system is very complicated. But when I was preparing this, I was thinking the C-Hobeck data, which is a little slice, might be easily or more readily incorporated as a first step. Because this push of readiness for discharge, I think, is really important. And I want to go back to our model of an electronic health record and say that I encountered some individuals. I was at a meeting in Europe recently from the Netherlands that are also working on completely interdisciplinary records that include interface with all of the disciplines' terminology. And they're trying to capture data and asking, how can we get data for more than one discipline? And they're trying, and they haven't done this yet, they're developing an interface with their system, which has SNOMED in the background, that says, if we come along here with the medical data and the clinical data and a history, there's a codable term in the medical history called nausea, because it comes in the medical history as a chief complaint. That term could automatically go into a nursing module in that record as a focus of nursing care for something that becomes not the medical diagnosis, but a chief complaint becomes the focus of the care plan for a different discipline. And they're looking at, it's the same patient, it's the same nausea, it's the same record. So if we put the information there once, we ought to be able to give it to the other discipline for their evaluation. That seems pretty efficient to me. And I think they're working on it. So what is in our future? I think this is in the hands and the vision of our leaders and our nurse executives and other leaders in health. I think that we could look at some of this work that people are doing in other places, and we could say, well, we've looked at it, and that's not what we want to do. I mean, there was one time where the NANDA diagnoses were used in nursing in Canada, and then we said we didn't want to do that anymore. The benefit is, of course, is that they're codable, so we can put these terms in the record. I think what's important to me is that as we move forward, we have an understanding of what other people are doing, and we make a considered judgment about what we want and what we don't want, and that we don't just move along not knowing what is going on in some other locations. So my final words actually come from some of the HIMSS data, which tell us to remember that this is a marathon. It's not a sprint, that it's going to take a long time to get wherever it is we're going to go. But if we don't have a vision of where we want to be 10 years from now, and we don't speak about that vision, we won't get there. And I know that if nursing and allied health don't advocate for what they need in a record, there's nobody else that's going to do it. So that I encourage people to just try to get as much information about how other people have approached this problem, and then take that part of it that we think is useful for us. That's it. And I'll be happy to answer questions.
Fantastic, actually. So thank you so much. You had shown in your research that actually there isn't any research that actually shows that the electronic record improves outcomes.
Well, it doesn't show that just because you have the record, you have improved outcomes. Okay. And I think that's what got us into all of the discussion about meaningful use. Yeah. That the record is a condition for us to be able to do some things. Okay. But if we don't do those things, we may never get there. Does that make sense? And this, you know.
Yeah, it helps, because it kind of worries me, because then in kind of your recommendations, you're saying one of the reasons that we should be doing this is because it does improve. We believe that it improves outcomes.
Well, we do. And I think that if we can, if we were at Dr. Odenbroek's hospital at the end of a year and had 50,000 records where we could say, what were we doing? What worked? What didn't work? How long did it take? We would be able to make different decisions about managing our care and perhaps managing our workforce. But so we need the record to be able to do that. But if we have the record and we go through some of those HIMSS stages, that doesn't mean that we're using it. It means that we got it there. And an important part of the electronic record is that the data are retrievable. So that in some settings where we're putting PDF files in a record, that's not a digital documentation. We've just got a paper in a different form. When we can manipulate the data and say, we've got data for a patient, but then we can pull out data for this particular kind of patient and look at what our experience has been over the last 3 months or the last year, then it is very helpful. So I think it depends on how you use it.
Thank you. That's helpful.
I'm sorry, you told me to do that.
You mentioned meaningful use, and I was wondering, in the Canadian context, because I think the context is a little bit different in the US, so do you see the way that meaningful use and terminology and the standards, whether the US and Canada will be implemented, in the US will be implemented as well?
I think the American system is different. Oh, the question was about meaningful use and of what we do in Canada. That we will follow what the US is doing. And the answer is, I don't know. But I think there's that issue of, what is it that we're doing with this data system? Because what an electronic health record is a data system. And are we using it in a way that makes sense in our managing and delivering care? And I think that we might, again, look at it differently than they do in the US. But that idea of it isn't just developing the data system. Okay.
I'm sorry, I missed the beginning. You may have touched on this. This seemed from the second half that I captured a very acute focus.
Mm-hmm.
And I'm wondering whether or not, from a patient perspective, let's say we had a classification scheme for areas of concern, is it too much for us to think from a system perspective of trying to standardize that same classification of nursing practice into a community system so we can track that area of concern for the patient, or is that just boiling too much of the ocean?
No, the question was, could we take some of these systems from an acute setting into home care? And the answer is, I think you can. The nursing terminologies that deal with things like nausea management, pain management, sleep disturbances, family support, caregiver role strain, those are all terms that are codable within these systems. And so, yes, those are things we encounter both in the hospital and many times in the community. And there is the Omaha system, which was developed by Home Care, which is a classification nursing system that is really focused on more of that community environment. So the question is it possible? Yes, I think it is. And I've heard that there were some units in Alberta that were using the Omaha system for home care, part of the community practice. But I don't know that for sure. But I hear things from students and various people that say, you know, this is going on. So it's, you know, I think the full scope of practice is possible in an electronic record. It's the same patient. And what we don't do very well that a fully developed record would do is when people move from one care environment to the other, from hospital to home, from hospital to long-term care, back to hospital to, you know, the record could go with them and the nursing concerns could come along as well. Because often right now we get the medical diagnosis and a treatment, but what were those nurses doing that we need to know about?
My question has to do with, I understand that VHA is already using Cerner,
Mm-hmm.
and I'm wondering, have they looked at any of this and have they embedded that into any of their Cerner application?
So the question was, has VHA, or Island Health now, implemented any of these terminologies into their record? And the answer is, I don't think so. I'm not aware of it if they have.
What do you think prevents us from doing it? Is it just that we don't know, or that I don't know that we can do that? Like what prevents? Because it seems like CHOVA's been around for a while, other ones have. Do you have a sense of the hesitancy?
Well,
The
the question is, what prevents us from doing this? I think we don't have a critical mass of people that are asking for it. That's what I think is preventing us from doing it. Where we have people who serve on various committees and have certain knowledge and certain input, but I think from our professional disciplinary perspective, we don't have a critical mass of people that say, we need this to document our care. And my particular concern about nursing and some of these other disciplines is that if we don't do this, you know, we've been saying for 20 years in this whole area of nursing documentation that if you don't name it and you don't record it and you don't document it, it never happened, and nobody will ever pay for it, and nobody will ever put it into policy because we don't know what it is. And so I've been an advocate for saying, let's put a name on those things that we do, and let's claim that, you know, that's part of our professional work. But I think that's one reason we're not doing it. The other one is that in every case in the literature, and I just gave you some examples, where people were saying we wanted to develop this nursing module within an EPIC system, they had to negotiate with vendors and they had to hand build something. This system that I showed you some screenshots of from Switzerland, they worked with a Swiss vendor because those nurses knew exactly what they wanted. And they said, we have to have this. So of course that costs money. You can't have a system as well developed as what they have without investing a lot of time and resources into it. So that's where we are.
What do you do in a situation where, like you say, nurses want specific things
The question was, what do you do when nurses say they want something and people say, well, it's not possible within our system? That is one of the reasons we developed a double-degree master's program for nursing and health informatics. Because these things, the way we're designing this system, the way we're implementing and rolling it out, that isn't possible. But if the clinicians say, but wait a minute, we really can do this, and it's essential for our clinical practice, people have found ways to do it. But I think the answer quite often is, well, that's out of scope. We have this, and you're asking for something new. And that's where I think we need the critical mass of people to all say, actually, we do need this. And we have to decide what part of it we actually need.
I'm just seeking some clarification. So you spoke about focus charting
Mm-hmm.
with codable wording, messaging, and you also spoke about free text.
Mm-hmm.
And so my question is, so is there the capability, if you're using a code set in the background, to use certain terminology in free text that allows the system to search text?
Yes. So the question is about the free text and the codable terms, and if you're writing something in free text, can you do like a data mining or word search? Yeah, so you can find it. The answer is yes. And in fact, in that system in Switzerland, if they went into that first screen and they started writing free text, if they were writing certain words, a codable term would come up and say, is this what you want? It's got a huge amount of decision support built into it. So it's possible. But what I would say is these are very complicated. And so that's one way to use the free text. The other is to say that I have a situation of sleep disturbances. I have to contextualize that somehow. I have to have a little bit of space in a narrative to tell you what that means. And it might be because a person's in ICU and we're waking them up every 15 minutes. And that still is a challenge for us to deal with, that person's sleep. So I have to tell you. Mm-hmm. Yeah.
So I panic when I look at this presentation because I know where we are in our bills. And I guess my question is, with some of the bills, we know that we can add things as we go. When I look at things like
Mm-hmm.
does that have to be built in early, or is there ever an opportunity, like, you know?
The question is, when do you have to put something into the system? And I'm not an IT person. I'm a person who's more knowledgeable of the interface terminologies and how do you get them in there. I would think that you could put them in later, but institutions sign contracts that this is what we're going to do. And if that's not in the contract, then it becomes far more difficult to add something later than it does if we're doing this as we're moving forward.
Thank you to everyone for coming. Appreciate you making your way down here this afternoon, on a Friday afternoon especially. And Noreen, I also want to say thank you to you. We very much appreciate you taking time out of your busy schedule to come and visit us here in Vancouver. And it's been both a privilege and an honor to have you. So on behalf of professional practice, this is a small token of our gratefulness for you being here today. So thank you. Thank you to all of you, and have a nice weekend.
Thank you.